In pediatrics, we are primarily an understudied population, but in pediatrics, because underserved and well-served patients get many of the same problems, we see a wide range of patients, including many also underserved patients. I'm going to kind of take it from the lens of the patients that I see. So I see a wide variety of patients, and I'm kind of divided into two groups. We see a lot of patients that I would consider normal, who have structurally normal hearts. And many of these patients are, as Mike alluded to, patients with more acquired type of diseases. And so the ones we think about immediately are dyslipidemia and hypertension, obesity, and things like that, which that is not an area of my expertise, but we definitely do see those patients. The group that we're seeing a lot of are patients who, because of poor lifestyle, just have a lot of chronic complaints that make people worried about their heart. So we see a lot of patients who are dizzy, we see a lot of patients who are fainting, we see a lot of patients with palpitations, we see a lot of patients with chest pain, and 99% of the time it has nothing to do with their heart, yet it's the first thing that everybody thinks about, so they get sent to us. So we do see a lot of those patients, and the frustrating part is that we can basically tell them their heart is not the problem, it's not the primary problem, but it really frustrates both the clinicians and the families to not be able to tell them exactly what the problem is. So they end up seeing a litany of subspecialists, and this ends up, creating a lot of overutilization. I mean, I see a lot of patients. By the time I see them, they've seen 3, 4, and 5 subspecialists, and really the only thing wrong with them is that they don't get enough sleep, they don't exercise, they eat all the wrong foods, and they're being bullied at school or having a lot of issues with social media and things like that. So that's a big group that we see a lot of, and that I feel like the inclusion of lifestyle medicine into our primary care practices, both in family practice and in general pediatrics, would really facilitate helping those patients and decreasing that overutilization of care, especially all the testing that comes along with it, and really decrease cost. I think exactly what you're getting at in the adult population. And we do have a lot of that on the pediatric side as well. I think that in pediatrics, and I'm going to expand it a little bit to include obstetrics, because I think that, if we can capture the family, we can capture the other way around. If we can capture the child, we can capture the family often. And so parents are very motivated to make changes, not only in themselves, but in their children, when their child is involved. So whether it be a pregnant woman who's interested in having her baby be as healthy as possible, and they're often more willing to make some changes. Likewise, in parents when their babies are newborns, and if you're talking to them about the improvement and optimizing health of their children, they're often more ready to consider making some changes than they would be if it was just for themselves. And often in changing the milieu for their children, they have to change it for themselves as well, because they find that having soda in the house for themselves and trying to get their children not to drink it kind of doesn't work. And so some of the challenges we face in pediatrics that I think is unique is that we have to sort of transition from dealing primarily with the parent when children are young, because the parent is the one that controls what's in the house and what's available for kids to eat, what they're doing for activity level, how much screen time they're spending. And then we have to go through the ultimate difficult period of time, which is adolescence, where children are really trying to separate from their parents, and they really don't find that anything that any adult tells them is credible. And they also partake in a lot of risk-taking behavior, not only from not eating the things that they're supposed to, but then also risky behavior in experimenting with drugs and alcohol and things like that. And then we have to try to then catch them again at the end when they sort of come around to be normal human beings at the end of all of it. And often they're out of our milieu by that time, because that, as someone had mentioned, brain development doesn't really continue and isn't completed really until kids are in their 20s. And so they have often moved on to the adult side by then, before they are really mature enough and come back around to having healthier behaviors. I do think that despite that, there is a point in really emphasizing it during the pediatric age range, because they often come back around to what they learned when they were children. And so I think emphasizing it and embedding those important lifestyle behaviors when children are young will help them to come back to that and be more likely to adopt healthier behaviors as they get older. And the other thing, as you pointed out, that Mike, that NIH funding only is 5% for children. Children are 25% of the population. So there's a large chunk of the population that is largely being ignored in evaluating and studying this group. And if we don't, rather than going and trying to teach old dogs to do new tricks, which I think I put on my slide, in the adult population, it seems it makes a lot more sense to just capture them when they're children and move on. And I realize that does nothing to our current generation of us old farts. But then, ultimately, as time goes on, really capturing people during childhood and embedding and instilling those good behaviors as they grow is really the optimum time to be involved. I want to switch hats a little bit to the fact that the other group of patients that I care for, which is predominantly the group that I take care of, are children with congenital heart disease. So patients with congenital heart disease, it's the largest congenital malformation is congenital heart disease. So we see a lot of patients ranging from the simplest congenital heart disease to very complicated heart disease. And many of my patients require multiple surgeries and interventions and things. And so I think one of the things that we have not done a good job at in pediatric cardiology and cardiothoracic surgery is that we've been so focused on getting those kids to survive that we really haven't, and we're only beginning to look at quality of life issues. And there really is not very much, if any, social and psychological support for these patients and their families. So many of the parents, after having experienced spending months in the intensive care unit with a newborn baby, have PTSD themselves, and they're not making really great decisions about what to do with their children. And then the children, probably as neonates, although I don't know that we have the greatest way of studying that, but then as older children, then when they have to come back, and for the child, to them coming back and having to have a surgery when they're 10 years old, when they were a newborn, when they had the first one, they don't remember that. All they know is they got a scar on their chest. Their parents remember it very well. But so for them, even though they're sort of a veteran of coming back and having surgeries and procedures, for them it's the first time. And so it's a very traumatic experience. And so, when I was also going through my lifestyle medicine course, and they were talking about how adverse childhood experiences greatly shape later behaviors and health behaviors in particular. Adverse childhood experiences play a huge role in that, and that's something that we really are not paying attention to. And I think this is probably true not only for cardiology, but for many of the other areas, childhood cancers and things like that, that we probably need to be spending a lot more time paying attention to. And then the other thing that I think is very fascinating is the whole topic that we've been talking about a lot today is epigenetics. So we've been frustrated as pediatric cardiologists in the fact that most of our congenital heart disease does not obey Mendelian genetics. We've been searching and searching and searching for genetic markers and for genes that identify or will predict whether people will have congenital heart disease to no avail. And so I think the fact that there's all of these epigenetic changes that can happen are probably playing a large role in it, and probably both prenatally as well as postnatally. And this would be an area that certainly would be ripe for research. And then the last group of patients that I take care of as well, and is sort of my area of expertise, is in patients with aortopathy. So these are patients who have primarily genetically mediated, so it's completely the opposite, who are patients who have vascular disease. So these are patients who are prone to develop aortic dissections, and they typically don't happen very commonly in the pediatric age range, a few in teenagers, but this is primarily a disease that then manifests itself during adulthood. But it doesn't get as much press as coronary artery disease, but it is a major cause of morbidity and mortality in adults, both thoracic and abdominal aortic aneurysms. And so again, these are primarily genetically mediated diseases. They have incredibly variable penetrance, so you can have multiple patients in one family with the same mutation that have very variable expression of the disease. And so, again, epigenetic phenomenon probably is playing a big role in that, and that's something that hasn't been studied. And I think the other thing is focusing a lot on vascular health. So I think the vascular system has been semi-ignored in medicine. There really aren't a lot of vascular medicine specialists. I've met the first few that I ever met recently, and has primarily been followed by vascular surgeons who are more interested in operating than really taking care of the medical portion of the disease. But I think a lot of lifestyle medicine really does focus a lot on improving vascular health, and so in many ways, including both carotid disease, coronary artery disease that we see a lot in adults, but also in aortic disease, and hopefully improving the risk factors and decreasing the risks of aortic dissection, because that is a very high-risk problem in patients. They look fine until they don't, and then there's a very high mortality rate with those patients. So that's kind of the areas that I'm interested in looking at. There are so many research opportunities, I can't even list them. I think in pediatrics there's a lot of low-hanging fruit there, both from a population standpoint as well as from individual diseases. I think one of the things that is a problem is trying to get any large studies performed. So I was a site PI in a big multi-institutional study that was done a few years back on patients with Marfan syndrome, and it took probably about 20 to 30 centers to be enlisted to get 600 patients enrolled. So I'm always jealous of these adult studies that have multiple thousands of patients, because we really just don't see that in pediatrics. I think we're getting better as we're starting to do more data mining of big national databases. So we're starting to see some of that in pediatrics, but we need to move forward and really try to improve that as well.
So thank you for giving me two opportunities to speak back to back. I mentioned earlier that I'm passionate about prevention, and that made me go and do a residency in family medicine. And I finished my residency 30 years ago. 30 years ago, I will tell you that in my practice, I didn't really have kids with chronic disease. I had an occasional kid who had ADHD, and an occasional kid who had asthma. But it was really rare to have children with chronic disease. And now it feels like there are so many children who suffer with chronic disease. And so the question that I'm really interested in is, can we prevent some of this? And I want to point to one particular example, and that's children with autism. In the 1970s, it was estimated that maybe 1 in 2,000 children had a diagnosis of autism, and now the CDC in 2014 said it's 1 in 56 children. 1 in 56. I mean, that is a lot of children being diagnosed with autism. And some people believe that we are more liberal in our diagnosis, but everybody believes that the incidence has gone up, and clearly our genes haven't changed in that direction. So why are we seeing so many children with autism, and what could we do about it? And so when I put my prevention hat on, I really think about what can we do to help people conceive healthier children. I mean, that's real prevention, before conception, right? We're really thinking about the future. Now, David Barker in 2004 published a paper where he talked about the fetal origins hypothesis. And he said that essentially the roots of disease, not just childhood diagnosed diseases like autism or ADHD, but diseases in adulthood like cardiac disease, or even later in life like neurodegenerative disease, have their roots in the womb. You are basically being primed. Someone said this earlier this morning. You are being primed for what you're going to experience as a lifetime of better or worse health, depending on what happens in the womb. And we all know that if you want a healthy womb, you got to get there before you get pregnant, because once you're pregnant, the central nervous system, the cardiovascular system, they're already developing. So it's a little late to start thinking about a healthy womb once you're already pregnant. And of course, we want to think about men too. Now, I want to emphasize what Sarah said yesterday. This is an environmental justice issue, because some of the things that I can mention that individuals can do, you could do if you're affluent. But what are we going to do for our nation? And the exposures, the environmental exposures you have, very much reflect your socioeconomic status. So let me talk a little bit about some of the things that we know. For example, if you take folic acid in the 3 months before conception, so the 3 months before conception is when the follicle is really developing. So even though all of the eggs in a woman's body develop during her fetal life, it's really those 3 months where you can perhaps influence the development, unless you could somehow get back to the grandmother. And the first trimester. There are 3 large association, not randomized controlled trials, but 3 large studies with tens of thousands of people that show that there is a lower association, about 40% lower in all 3 studies, of severe learning disabilities and autism if the mother took folic acid in the 3 months before conception and the first trimester. So just as a public health thing, the American College of Obstetrics and Gynecology, the American Academy of Family Physicians, the American College of Pediatrics, the American Association of Pediatrics, and the United States Preventive Services Task Force all recommend folic acid to women of childbearing age. So what percentage do you think take them? Anybody? 0. Not 0. 34%. So 1 in 3, essentially. So we're not doing a very good job. And what percent of pregnancies in the United States are unplanned? 50%, yes. So it's a little late to wait until you find out you're pregnant. SSRIs. I am not anti-medication, although I would say that SSRIs have been questioned in terms of how valuable they are. But SSRIs, Prozac, Zoloft, Paxil, if you take an SSRI in the year before you get pregnant or in the first trimester, you have a double or triple the risk of having a child with autism. Now, double or triple the risk. How many people are told, why don't you just stay on that SSRI because that way your depression won't come back? Or someone who had mild depression where the evidence is really that it's no better than a placebo. Wouldn't you want to know this if you were planning on having a child, that perhaps you wanted to get yourself off of an SSRI, and it can take a long time to wean off of them before you conceived. There are medications like valproic acid and acetaminophen. Tylenol was supposed to be safe during pregnancy. We have a big study now that shows an increased risk of ADHD in children. Tobacco and substance abuse, that's more part of conventional medicine. Everybody knows you shouldn't smoke, you shouldn't use substances when you're pregnant if you want to have a healthy child. Air pollution is associated with an increased risk of autism in children. Advanced paternal age, we think a lot about moms and their biology, but it turns out if the father is older than 45 years when he conceives, and this is again a cohort study, it's the Swedish cohort study, but fathers over 45 have a 13 times increased risk of having a child with ADHD, a 25 times higher risk of having a child with bipolar disease, and a double the risk of having a child who's later diagnosed with some kind of psychotic disorder. So fathers' ages, how much are we really counseling from a lifestyle perspective that father's age matters too? Obesity and malnutrition, the Holland study about famine during World War II, this is some of the epigenetic data, and similarly we have epigenetic data that maternal stress during pregnancy is passed on to the fetus. And then the big question is environmental chemicals. To what extent are environmental chemicals causing this epidemic of chronic disease in children? We don't know. We can't ever have a randomized controlled trial where half the children, half the women during pregnancy are exposed to an environmental chemical and half are not. So this whole idea of RCTs being the gold standard for evidence obviously doesn't work when we're thinking about something that the World Health Organization estimates is responsible for 25% of deaths worldwide. 25%. So I think also lifestyle medicine has to include that category of environmental medicine if we're really going to move the needle. In the US, there was just an article a few days ago, 88,000 deaths per year attributable to environmental chemical exposures. Mostly they were looking at air pollution. So these are the things that I think that are really not thought a lot about, and yet they are what are setting people up for a lifetime of better or worse health and has to be part of lifestyle medicine. So one big question, how would we help women detoxify before they get pregnant? We don't know. But I'll tell you, do you know the most effective way that women detoxify from fat-soluble, that's a clue, from fat-soluble chemicals that are in their bodies? Breastfeeding. Because breast milk has lots of fat in it. And so we move the environmental chemicals from the mother to the baby through breastfeeding. Now, breastfeeding is recommended by everybody, and I'm not saying that it's not a wise choice, although there are people who elect not to breastfeed because they're worried about the environmental chemicals. That especially affects the first baby. The second baby, the mother probably only has 2 or 3 or 4 years to accumulate more environmental chemicals. The first baby is the first 20, 30, whatever years of her life. This is a problem. We really have to figure out how to help women. Now, some of the things that Dr. Trisande mentioned yesterday, bisphenol A, for example, within 3 days you get it out. You know, your kidneys are really good at moving it out. But the fat-soluble chemicals, the ones that are stored in bone, these are much more challenging. So could we, from a lifestyle perspective, create some this is what I want to do, but create some kind of haven for women who are going to conceive, and men as well. What would it be like if we actually mobilized that everyone got a water filter that effectively removed lead? Think about Flint and the women who were pregnant during that time. What if we could mobilize safer pest control so people weren't spraying their houses with pesticides? HEPA filters that could remove, and HEPA filter vacuums that could remove some of the toxins that are in dust in households. Organic food. We have a SNAP program and a WIC program. Couldn't we have a program where we made organic food available to pregnant women? Again, we know it dramatically reduces the amount of pesticides. Prenatal vitamins. When the Affordable Care Act was passed and we made prevention things free, I called into one of the phone calls and said, why aren't prenatal vitamins free? Everybody recommends them as prevention. Why are those not included as one of the free interventions for women of childbearing age? And then the stress pieces. It is extremely stressful to be pregnant in the United States today. Again, unless you're from an affluent family. It's very expensive. You have no job security. So maybe when you come back, you're going to lose your job. You have little support for breastfeeding. What could we do to change our society to make it a better place for us to conceive and raise healthy children so that some of the diseases, the chronic diseases, that are not just a reflection of lifestyle after birth, but during fetal life. Thank you.
So I was thinking just a little bit about issues related to care of the underserved, and Mike knows that's been my passion for all the 22 years I was in the Army, as well as the 18 and a half years I've been here in Pittsburgh. And I realized that there are so many aspects of care for this population that are within the realm of what we can do as clinicians. I think it's been wonderful to listen to Stacey and to Victoria, because the truth is that there are a lot of things that can be done in the public health perspective, no doubt. And there are things that can be done in those, and I won't re-echo those things, but as someone who's taken care of pregnant women for most of my career, those things are absolutely in the forefront of my mind as well. But the first and foremost thing I would say about care of the underserved is a team approach. And this is not the way we are incentivized to pay for care. We pay for care as it is delivered by physicians, then maybe physician assistants and nurse practitioners. But in order to care for a challenged population, we need to pay for all of the members of the team. And many know that when I first came to Pittsburgh, I was concerned that there was no front door to UPMC. That you could get in if you had a gunshot wound or crushing retrosternal chest pain, but if you didn't have insurance and you didn't have those presenting conditions, there really was not an easy way to get care. And so we were able to start the first federally qualified health center within the system so that we could care for those who didn't have a plastic card. And the first thing that became clear from the 330 federal program or the FQHC program was that they fund teams. And they fund, you have to have at least 4 approaches to care. You have to have medical approach, behavioral, and these were the ones we chose. We chose medical, behavioral, pharmaceutical, and dental. Because it was clear, and I was appalled when I left the federal government to see how little oral health care was being provided, and the number of people in their 20s with no teeth in their mouth, or few teeth in their mouth, and those there needed to be pulled. So what it amounted to was we realized that we set up a health center that provided access in those 4 areas. And yet, what we found is that if you don't have a subsidy outside of your system, either from philanthropic sources or from FQHCs, you can't pay for those team members because you can't bill for their services independently. And I don't know how we could continue if we didn't have clinical pharmacists in each of our family health centers. So we have clinical pharmacists in every one of them, social workers and or psychologists, we have nutritionists, we have oral health services, and though you have to have them co-located with your medical care to reduce those other barriers that occur in populations of low socioeconomic status. So we've got to be able to facilitate payment of those services separate and distinct from delivery of medical care to this population. The other thing is we realize that lifestyle medicine is all about patient education. And after patient education, community education. And we have to pay for that. We have to figure out how to associate the cost of better patient education, not from social media, not from what's on television, not from those, but patient education that comes from the source of those who know the health data the best, and then provide that education on a regular basis in a palatable fashion to this population. And that means when we talk about, well, at a 6th grade level, I can't tell you how many times I've reviewed things, I say, my patients will not understand this message. You may think this is a 6th grade level, but we have to make sure that it is actually intelligible to a population that has limited literacy in that sense. The other thing is that we need to realize that first and foremost, we must educate ourselves. A lot of what I have done since coming here is running medical student courses, master's level courses in our school, in our other schools of the health sciences about cultural competence within the clinical workforce. And part of that cultural competence is understanding the cultural determinants and recognizing what it means if your first language and your language of comfort is not English, and yet everything is delivered in that language, what that means in terms of transmission of information. Understanding the faith-based background of our patients and how that influences what they're willing to accept and what happens. Understanding issues related to age, understanding issues related to environment and geography and whether they are here in a legal status or not a legal immigration status, and a variety of other things, not to mention issues related to socioeconomic status, ACEs, and the adverse child experiences that they've experienced, to which they've been exposed, whether they're what is their sexual orientation, what is their vocation. All of those are things that are part of their cultural framework that we as clinicians don't know very well. And right in the middle of all of that is discrimination related to any of those or multiple ones of those different factors. And what we're seeing is that when we discriminate against our patients in a variety of ways, their health suffers. And we found that there's discrimination, unfortunately, alive and well within the health community. It's discrimination against those of us who are clinicians who don't look like the majority individuals, discrimination against our patients, discrimination between what neighborhood they came from and what's accessible in those neighborhoods. And if we ignore that, we will not be able to adequately care for these underserved populations. I think the other thing is we need to be cautious about this assumption that high tech will solve these problems. Every time we bring up something, say, well, we have an app for that. Okay, to have an app, you need technology. You need to have access to technology that you don't pay for by the byte, or you don't pay for by the minute. And so we decided that, okay, to give them access to care, we're going to let them do teleconferencing or telemedicine. We're going to let them access by an app. That is not accessible to large segments of the population, especially those that are lower socioeconomic status or don't have good, aren't tech savvy. I'm one of those people. And I think about over the holidays, my kids saying, okay, we're going to show you, Mom, how you do that. I'm going, wait a minute, you got to say it differently, because I'm missing it. I'm missing what you're saying. And I consider myself fairly knowledgeable. I mean, you have to be, don't you, to be in medicine these days? And yet the assumption that we're going to use technology in our most challenged population to solve the access issues, to solve the education issues, to help them make appointments, I think we're fooling ourselves. That is something that's going to come. It's not here yet. And it's going to be expensive, and there's been some good data to show that. Technology has added a lot more things available. It has not reduced the cost of care. So, matter of fact, we've had to invest more in technology in order to get these things. So the thought that we will be able to use technology instead of people, and then we will reduce the cost of care, is a fallacy. It may come soon. It's not here yet, for sure. The other thing is that we need to realize that we need to understand who's coming into healthcare now and what are their backgrounds and the difference between what they look like and the patients for whom we're caring. As you know, my colleague John Mayer, we were talking about who's coming into medicine. And when you sit in the admissions committee now, more than 50% of the students in the admissions committee are not requesting financial aid anymore. Matter of fact, it was 60+% who said, no, we don't need financial aid to come to medical school. I needed financial aid to come to medical school. And I became a real close affiliation with the federal government in order to be able to figure out how to pay for this. But who are they learning on? They are learning on we're using students who are arguably the brightest, the best financially stable because they can either have the money or can borrow the money, and they are the healthiest. And who are they learning on? They're learning on the most disadvantaged, the least literate, and those who, for one reason or another, have not been able to get the education they need. And we have to be understanding of that so that we can educate those of us to provide the care for the underserved that is necessary. One of the things we've also learned, as many of you know, we've had a long-term 12-year relationship with building family medicine residencies in Asia. And specifically in Japan, we spent a lot of time there. And we've been working with a 1,200-bed teaching hospital in a part of the country that is family-owned. And it was family-owned by the family that owned the major industry within that community. And they decided that the best way to ensure the health of the population who worked in their plant was to provide them a hospital. It was really interesting because last year I had an opportunity to go to the 100th anniversary of this hospital and be one of the speakers to talk about how seeing what a family could do when they provided grocery stores for their community, they've subsidized the educational system, they have not only, since we've started working with them, gone from 1 hospital to 8 hospitals. One of those is a primary care hospital that we were able to work with them in designing. And one of the things we encouraged them to do was to start a home health program. And this is a home health program that is not run by nurses alone. It is a home health program that is made up of physicians and nurse teams that go into the community and go into the home to provide care for people who are, believe it or not, cared for at home by family members who are quadriplegics with ALS. Caring at home for family members who have all other types of debilitating diseases because they don't have the nursing home system that we have here. And what they did was they realized the importance of teams, they realized the cost benefit of them, and they also realized that they engaged family and community in all decisions related to healthcare. I think only if we do those things are we going to be able to provide the needs of this population that is so terribly underserved that we don't think about because they don't make us money up front, but they cost us money on the back end. So I would probably close with saying that when I was a medical student at Fort Sill, Oklahoma, a long time ago, one of the adolescent medicine specialists who I work with said, the thing we need to keep in mind is we look at different things when we want to choose the physician who's best suited to take care of us. And he says, and I would flip and say, patients don't look at the same things that we do. They're not looking at the degrees on the wall. They're not looking at what institutes or honorific societies we're members of. They first of all look for availability, affability, and ability in that order. Availability, affability, and ability. And then sometimes when they're adolescents, they look for confidentiality. But the bottom line is the things that we are incentivizing, that we're paying for, that we're promoting and we're putting on all our ads are not necessarily the things that the patients are looking for when they choose their access to care. Thank you.
Excellent, excellent. Thank you. Questions or comments for what a great panel. Leo, first to the mic.
Leo Trisandi, New York University. I'm going to pivot. I apologize. I'm going to pivot away from the last presentation to the first two for a few minutes, but it was wonderful. And I'm proud to say that I'm at NYU School of Medicine, which now is tuition free, in part hopefully reflecting an effort away from that activity. But I'm going to pivot to a bit of a provocative or maybe more controversial comment, and that is that there we go. I had to do a double take this morning when I looked at the beautiful images of the foci of the ACLM, which doesn't really have environment there. There's a risky substances designation, but that really refers to drugs of abuse, etc. It's great to be part of this, and I'm happy to contribute, but in addition to driving the research agenda the way we need to go, I know there's some leadership of the ACLM here, but I think it's time to consider the breadth and bandwidth of ACLM going forward. I mean, I'm happy and delighted to be part of this, but I think it's high time. For example, I saw a question mark next to environmental chemicals. I probably would have crossed the question mark and really said, well, which environmental chemicals and how and when, et cetera. Thank you.
Well, I'll jump in there for a minute because I was there at the beginning, so to speak, along with others, when we pulled together the American Academy of Pediatrics, Family Medicine, ACP, ACSM, American College of Preventive Medicine, and what was then a very nascent group of small physicians called the American College of Lifestyle Medicine. And the genealogy of that group is primarily clinicians, some of whom have a population-based focus. They might have an MPH. They might have been in preventive medicine. But in many ways, what they were seeing, and the driver, I think, primarily, was what they were seeing day to day in the feudal practice of medicine with the application of more and more prescription drugs, more and more devices, more and more, et cetera, and saying nobody's equipping us as doctors with the root cause skills or even the understanding of what does that. Having said all of that, the maturation of the organization, the timing of the science in your book 10 years ago, so now we're at a threshold where new data, new science creates a new type of emphasis. And so, to be honest with you, Leo, the reason you're here is because we needed you here. The lifestyle 6 medicine domains do not have environment. Any type of behavior change requires 3 things. Knowledge. Health education doesn't work by itself. If it did, we wouldn't be here. The second is competencies. What are the skill sets that I've got to make the knowledge actionable in my home, in my school, in my clinic? And the third is a support system aided by a supportive environment. If the environment, broadly defined from small to big, is toxic or is non-supportive, you're not going to get to the competencies you need to hit those 6 domains. So that's an offline conversation, but thank you for bringing that up because it is not a question mark anymore. And it really is there, and that's why your presentation yesterday was so timely. So I think that's good. If that's okay for all my colleagues, Dexter and others will take it back. Steve. Oh, I'm sorry, Wayne, you're up next.
Yeah, so I just, I agree, and Leo knows because I talked to him about this yesterday. I think we need to have this more, and speaking from the American Board of Lifestyle Medicine, we don't think about cigarette smoking, we think about smoking and toxic exposure. So there is a place at some level, but we need to highlight it more. And I just thought it was a great panel, and I really appreciate the childhood and the prenatal importance of that. I mean, that's incredibly valuable. The comment I wanted to make is my experience is that lifestyle medicine will never thrive in a fee-for-service environment. It needs to be a value-based thing. And the people that will drive us into value-based, one is employers, and we're trying to work with them, although that's it's not as easy as you might think it might be. But the other is the federal government. And Medicare has actually done a fairly nice job. And I believe, Victoria, tell me if I'm correct, that most of your data was with Medicare patients. Is that?
No.
It was mostly with employers? Employers. Interesting. But Medicare has done a reasonably good job of pushing into value-based. Medicaid has not. FQHCs has not. So I'm curious if you have any feedback to that and what we can do to put Medicaid on the value-based path a little bit more.
Well, I think that actually in Pittsburgh, there's more attention now from our health plan towards looking at the Medicaid population because it's becoming, what, 40% or 40 to 50% of those insured by our health plan. And they're recognizing that if there isn't attentiveness to this, we're not going to be able to reduce the cost of care. I think the other thing is they've started by having practice-based care managers paid for by the health plan embedded into the larger, in our family health centers. And we have 7 family medicine residencies here, and so we've got health centers all over pretty much 2/3 of the state now. The challenge you have there, and I say that this is insurer-driven, but it's not necessarily supportive of the clinician. What do I mean? We take care of patients who are not part of the UPMC health plan. So if the practice-based care manager can only support those patients who are a part of that health plan, then we've got to figure out what to do with the other patients that are parts of other health plans. So we need the practice-based care manager that's usually a certified diabetic educator who spent a lot of time. We need them to work seamlessly with all of the patients who walk through our doors. So I think it is currently, it's successfully health plan driven for those who are members of that plan, but very few of us, unless you're at Kaiser or, are going to be able to care for patients who are only covered by one insurer. And that adds to the burden and the burnout of primary care physicians who are having to juggle. So who pays for your care and how do we do this and what do I do if you're uninsured and all? I mean, we have figured out how to do it. It's not efficient.
Right. Steve?
I'm inspired by Leo to be provocative, so forgive me if this makes people uncomfortable, but I do think it needs to be said, especially as I'm thinking ahead to the white paper that you're hoping to write. So the world I come from now, where my colleagues working in the area of social determinants of health and health inequity, would probably be very uncomfortable about the name of this conference and the use of lifestyle medicine as a way of describing what you're doing. And it's important to understand where that's coming from, to be sensitive to it in what we do. So the concern is that obviously we know from the science that health behaviors are very important and we all need to live a healthy lifestyle. But when we talk about, for example, at our center, we've documented 15, 20-year differences in life expectancy across cities, the argument that's often adopted by a large member of our population, a large proportion of our population, many politicians, is those people have poor health outcomes because of their lifestyle. They choose to live the way they do. And the evidence that we've discussed over the last 2 days could easily be cited to say, you see, it's driven by these behaviors, they're not adopting these behaviors, it's on them that they're having these bad health outcomes. So back 20 years ago, the field began moving away from this notion of thinking about this exclusively as a matter of individual behaviors to recognize the socio-ecological determinants of our health and to recognize that our behaviors are shaped by our environment. But I think I'm using environment in a different way than Leo did. So I think it's worth unpacking, if we're going to bring environment in, which I totally support, unpacking what we mean by environment. The environmental issue that Leo just raised is environmental exposures and toxins and so forth, which I think has to be on our radar, and climate change for that matter. But there's also the social and economic environment in our neighborhood environments that make it possible for people to adopt or stand in the way of them adopting the kind of behaviors that we're interested in here. So I think it's very important for us to couch the agenda that you want to put forward in the white paper in a way that's sensitive to that and doesn't feed into a toxic narrative that is related to discrimination and racism, frankly, in how people explain health disparities.
I'll jump in a little bit there. As somebody who, from the outset, was uncomfortable with the term lifestyle medicine for historical reasons. But I think for the leaders in this room and for all of us who care, whether we are in primary care, whether we're in public health, whether we're in focused areas of research to impact human health, getting the right message in the right framework, if we're talking about a white paper that informs research funders, federal agencies, foundations, is critical. And so I can't find it because I'm not as adept on the slides as Yorm is. But the reason that we put up that slide on day one, slide 3, with the triangle that said what I eat, how I move, and what I think, which taught religion, spirituality, connection, purpose, passion, right there. It had the framework of a magnetic field: home, school, workplace, neighborhood. This paper has to speak to all that, because otherwise it could backfire with the blame the victim thing and the false sense, even among the wizened physician colleagues in this room, that we as physicians can fix this without those other things. It's a community movement. I mean, so if you're talking even to our sponsors, Ardmore or Pitt, what you heard today is it's the community of Ardmore we have to help. Oh, by the way, I want a doctor who can get you off your insulin. And oh, by the way, I want a doctor who understands some basic stuff about why those 6 domains maybe synergistically create early heart disease in a 6-year-old. Or maybe even it happens upstreams of preconception, right? So we'll have to do that, and Steve, with all due respect to you, you're getting to our punchline here pretty soon at the closing of this meeting. But we're going to be looking for a writing team that represents the brightness and the passion in this room, that pulls together the content that we probably have a lot of, but it's the construction of that message and the nuance that you're talking about that means it's either going to be impactful or it could invoke antibodies, because it's not just a little church of people who believe what we might have talked about here for 2 days. You're now in the big end, right? And so all of those things, I really appreciate that comment, because I think it's timely and I think buyer beware. But we can work that, because the perspectives in this room have all of that. There's not a day that Jeanette doesn't do something, Victoria does, or I don't, in my role as a medical director of the health plan, saying, give me the zip code of the community and where's the nearest church. That's where we need to be.
But I think we also have to add government, because, you know, we got lead out of gasoline with government regulation. We right now have a really weak EPA, which makes it harder for us to protect ourselves from environmental chemicals. We don't model ourselves like European countries using the precautionary principle, where industry has to say this is safe and therefore can put it on the marketplace. We have to prove it's unsafe. So I think there are things that individuals can do, and then I think there are things that we as a society, involving our corporations and our government, have to be done if we want to have a healthy society.
Dexter.
I would just add to this conversation. I appreciate that question as well. One of the reasons we call it lifestyle medicine is because we want practitioners and clinicians to understand that, to our earlier point, this is very important to the prevention, the treatment, and the reversal of disease. And it's a very powerful intervention. And so while all of our patients live in the context of social determinants and the environment and where they live and work, they also go to physicians that are prescribing medications and making recommendations to those patients to treat their problems. And so what we want to have is, on the level playing field, lifestyle medicine also as an intervention. So just like I hand that patient a statin, I also want to be able to talk to them about their sleep and about how they move and those kinds of things, and use that as an intervention to deal with their high cholesterol or whatever. Not to blame the victim any more than I'm going to blame the victim that, you know, needs a statin or an aspirin or whatever else. But I want clinicians to be trained and educated, as well as the patient to also understand the power of some of these modalities. And in fact, it's actually empowering to those people instead of taking them out of the victim mode, because they can actually see and understand how they can actually direct some of these things on their own. Now, we do still have to help them with these other things. Again, this exists in this larger environment that we've been talking about, so we don't want to lose sight of that. And so I think, Mike, when you do write this up, you do it in a way that kind of puts it in that context.
When we write this up.
Yeah. Oh, when we write it up. Yeah.
Thank you.
And
Dexter, you're
another thing,
absolutely
too, is that what we're talking about is fundamental to all medicine. This isn't something that just some of us do. This is something that everybody in medicine and public health should be doing. These are the things, and we have the evidence that shows that it not only works through the observational studies, but we also have conversations now about epigenetics and other things in terms of the mechanisms of why it works. And so this is very powerful.
So as a quick insert here, one of the things we've done, we've tried to make it easy for busy clinicians who don't know these 6 domains to be able to literally, in 3 clicks, prescribe coaching engagements for their patients. So on this panel, we actually launched 2 months ago now, the first, to my knowledge, in the country of family health coaching. 9 weeks of family health coaching dispensed by pediatricians or family docs or internists who know that they might be motivated by their 12-year-old kids vaping, then maybe that they themselves as an adult should stop smoking. Write a prescription for a 9-week curriculum to help your family live healthier lives, and the doctor gets the note back in 30 days as to how the family's doing. The doctor prescribes, the doctor gets the feedback, but the doctor doesn't have to be an expert in behavior change or have motivational interviewing. They write a prescription in much the same way. So scalable solutions that can hit the costs as well as high-tech, high-touch. People like touch, people like talk. We're hardwired for eye-to-eye. But there's a lot of people who don't necessarily need it or want it. So, have it your way is kind of what we do. Paul, last comment. Go for it.
I would like to respond to your comment about there's an app for that. And there's a concern, of course, that we're just throwing technology at people when it's going to solve problems, right? So, and actually in my own field of neurorehabilitation, we have to write a meta-analysis to show to the community that if you go to Best Buy and buy a computer game and throw it at your patients, it's not going to work, right? It's all about what are the principles that are actually hidden in that technology. And the point is, we cannot just deny the potential of technology because we need, as Mike's saying, scalable solutions. How do we get scalability without relying on technology? We just don't have enough humans around to send them to all our potential users, right? So we are in that sense condemned to look at technology, but we have to think carefully how we deploy that technology, how we build it. And that's, again, the link to one of the themes that I think is coming back regularly. For that, we need theory. We need to understand how humans engage with this technology. We need to understand what are the exact principles we want to deliver to our end users. So without a clear model of our user in health and disease, technology is going to be worthless. But we cannot be without it because we need scalable solutions. Again, it has a strong request coming from the need for technology. We also need advanced models and theories about our users. Without that, it's not going to happen.
So that's the best teaser for after lunch. Paul will be on a panel where we really go out there as an expert in brain science. Right, you're so strategic.